guys, today I want to talk about bipolar disorder, which is a term that does get thrown around loosely in society and the media to describe people who are just generally unstable. And this has actually had an influence on the frequency that it gets listed as a diagnosis by psychologists and psychiatrists, because I see so many people who carry that diagnosis but that don't actually meet the full official criteria for bipolar disorder. This used to bother me a bit when I was in my residency training because anyone in their training has a more idealistic view on how things should be done. But now that I've been in practice for a while, it bothers me less and it can actually be helpful in describing to patients just generally what they might be experiencing as a cluster of symptoms. But what does it really mean when we talk about bipolar disorder? Well, it's meant to describe a fluctuation between depressive episodes and manic episodes, like traveling on Earth from the South Pole to the North Pole. And people, when they're in the manic phase of bipolar disorder, can be some of the most fascinating and entertaining patients that a psychiatrist can treat. These are people who have boundless amounts of energy, they don't need sleep, they're highly engaging, they're often hypersexual, they can be impulsive, and just generally loving life, as if they were high on cocaine for an extended period of time that can last for weeks or even months. But eventually, the lack of sleep catches up with them, and they can become erratic, impulsive, delusional, paranoid, and do things that put them in danger because of their impulsive behaviors, and often suffer financially if they're impulsively spending all their money on whatever kind of delusion they're experiencing. So, as an example, one of my favorite patient stories I've had recently was a guy I treated a few years ago. He was in his early 60s and he was in a manic episode. He was brought into the hospital, into the emergency room, after he was driving erratically on the highway and actually rolled his car with his ex-wife in it. She was okay, and after a couple days on the medical floor, he was okay, but his behavior was out of control and he ended up on the inpatient psychiatric unit. He didn't need sleep, he was highly energetic, and he had the delusion that he was the founder and head coach of the first United States Olympic miniature golf team. And he would not stop talking about it, and he was convinced that this was a reality. He had actually created a whole online presence about it, was talking ad nauseum about the type of equipment that he was using, the Olympic committee that he was engaged with getting miniature golf on the docket for the 2022 or 2024 Olympic Games. And this was just his complete, utter reality. He needed a few weeks on the unit, and we eventually were able to, using medications, bring him down and out of this delusion. But this was after he had spent pretty much his entire life savings invested in the creation of this miniature golf team. So, as you can imagine, it's challenging to get people in a manic phase into treatment because they often really like their high. They don't want to come down. So we most often see people in the depressed phase of bipolar disorder. This is when people are isolating themselves. They're fatigued, they have no energy, they have no interest in doing things, and they might even be thinking about killing themselves. So this is when they come in for treatment, and initially the diagnosis might be a major depressive episode. But then as we talk to them more and get more of a history from them and their families, it might actually become clear that in the past they had manic episodes or symptoms like that, but just never received treatment. And if this is the case, then we'd change the diagnosis to bipolar disorder. But the number of people out there who actually have these remarkable full-blown manic episodes and depressed episodes is actually not as high as the number of people out there who experience more subclinical symptoms of mania and depression. And as psychiatrists, we'd call them bipolar 2. But this is the group of people who often aren't hospitalized and could definitely benefit from treatment, but are the folks that people, their family, their friends might casually refer to as being bipolar. Now, the subclinical manic phase, I find, comes in two varieties. Either someone is overly energetic and engaging and highly productive, unless they're trying to start too many things at once and just kind of never get anything quite done, or they're overly irritable, frustrated, annoyed, and kind of have a short fuse. These are the type of people that the symptoms might get managed by their friends and family just sort of knowing when to avoid them at certain times, and dismissing him as he's just got a bad temper. Well, this of course isn't good because it's going to have a negative impact on your relationships with those people around you and can have consequences on your physical health if you're managing the symptoms by doing things like binge eating or abusing drugs and alcohol. Of course, there's also these sort of subclinical depressed phases where people might not be so depressed that they're thinking about killing themselves and completely isolating themselves, but they can still have depressed episodes, much like the type that I described in my video about depression. But it can be particularly confusing to family and friends and the patient when they're oscillating between these two moods, both depressed phases and manic phases. So what do we do to treat these patients? Well, first, you got to be man enough to recognize that something's not right. There's something inside you that's creating some instability that's affecting your relationships, your mood, and your physical health, and it's time to do something about it. First of all, you got to maximize your diet and exercise. If you're eating crap and not physically fit, then you're just going to be less capable of managing stress and managing swings in your mood. So you got to optimize your physical health to set yourself up for success. Second, and I hate to use this word because it's been so overly utilized in the media for the last few years to describe whiny youths who are just feeling entitled to be bothered and insulted by any little thing, but you do need to identify triggers. Usually, there are stressful events or circumstances in a person's life that will trigger a manic phase or a depressed phase. And recognizing those things can help you predict when you're going to have a mood change and help you to better manage it. Also, sleep is vitally important because people with these types of mood problems can often have disruptions in sleep. People in a manic phase have a hard time getting to sleep, and people in a depressed phase often have a hard time staying asleep. They wake up at 1 or 2 in the morning with racing thoughts and can't get back to sleep. One thing I often recommend to patients to try is to take melatonin, which you can buy over the counter and is a chemical that your brain actually produces naturally when it's dark outside to tell itself to go to sleep. This isn't just a sedative to knock you out for the night. It's actually therapeutic because it helps to reestablish that proper sleep-wake cycle or circadian rhythm that's so disrupted when people have this kind of a mood disorder. There's medications that can be helpful, and we certainly use those quite frequently. We have antidepressants that can be helpful for treating someone in a depressed episode. And we have medicines that are broadly referred to as mood stabilizers that can help someone in both a depressed phase and in a manic phase. Medicines, of course, take time to work, and you have to establish care with a provider who's going to manage them, and they can come with side effects like weight gain or sexual side effects. If medicines haven't worked, though, I also recommend sometimes to patients to try electroconvulsive therapy, or ECT. ECT's been around since the 1940s, and it's actually been the gold standard of psychiatric treatment for mood disorders since that time because it is so effective. But of course, the technology has progressed quite a ways in the last 80 years, and it's a much more refined and safe procedure now, and it's highly effective at stabilizing people's moods. But I'll talk more about that in a later video. So the take-home point for now is that fluctuating between depressed episodes and manic episodes can be confusing, uncomfortable, unhealthy, dangerous, and even ruin you financially. But there are ways to manage and alleviate the symptoms which can improve your life and your health.